Good evening, all of you. I guess all of you are having a very long day, right? After the exam, the very next day, we are having a good discussion of all the questions that were asked. So, I'm Dr. Jazeer, your dermatology faculty at Physics Wala Meded. I hope I'm audible as well as visible to all of you. So, just confirm me in the chat box. I'll also just check the chat box as well. One moment. So, allow me a minute. So, we'll just start it now. Yeah. So yes, all visible now. Thank you so much for confirmation. So what I'll do right now is we will just discuss about the questions from the second paper. Okay, yesterday we had a long recall where we discussed about the questions that came in the first one. So right now let's start about the second paper. If all of you ready, just confirm with me in the chat box and let's begin now. I think this first question that we got yesterday, I don't think that any one of you must have got it wrong, isn't it? Very typical thing, because every time in the NEET PG exam, even in the last INI CET, they were repeatedly asking you regarding this investigation. So what is the name of this investigation? So this investigation, is it a direct immunofluorescence or an indirect immunofluorescence? Yeah, this is going to be a direct immunofluorescence, right? A very important investigation when it comes to vesiculobullous diseases. So in all of those vesiculobullous disease that you must have learned before your exam, like pemphigus vulgaris, pemphigus foliaceus, bullous pemphigoid, linear IgA disease, etc., everything that comes under vesiculobullous disease, we all have learned that there is some kind of a specific DIF finding. Now, what do we see here? I think a similar image was asked where it was a fishnet pattern, isn't it? What is the name of this pattern? This is going to be a fishnet pattern or a chicken wire pattern, isn't it? Or a chicken wire pattern. So here, what do you think is the right answer whenever you get the fishnet or a chicken wire pattern within the epidermis? Because this entire area is now the epidermis. The layer below is going to be the dermis, isn't it? So in the epidermis, if you get a fishnet pattern, can anybody answer? I hope all of you got it right, because whenever there is a immunofluorescence that is taken up in the epidermis, it means that there is some defect in the epidermis. So this defect in the epidermis can be because of desmoglein 3 or it can be due to desmoglein 1. Where are these desmogleins present? They are present over the surface of a keratinocyte. That is the reason why we have this kind of a fishnet pattern or a chicken wire pattern. Now, the correct answer should be some disease which is going to have a intraepidermal blister. Now, see the options: pemphigus vulgaris, bullous pemphigoid, linear IgA disease, dermatitis herpetiformis. Now, in all of these, I would say that pemphigus vulgaris should be the right answer. Why? Because we have a intraepidermal blistering disease here, because the bulla is already formed in the stratum spinosum usually, whereas in bullous pemphigoid we get the okay, in the bullous pemphigoid we will be usually getting the blisters around the dermoepidermal junction, isn't it? In linear IgA disease also it is going to be in the dermoepidermal junction. In dermatitis herpetiformis over the papillary tips, correct? So here I guess all of you must have got it right. The correct answer is pemphigus vulgaris. So now let's move to the next question that was asked. See, there was a question about acne vulgaris, right? So can you just confirm whether if they asked you directly कि severe acne vulgaris का treatment क्या है या फिर something else was asked? Yeah, so one of you is answering it as isotretinoin. See, we all know कि when it comes to acne, if it is any acne which is not very severe, जैसे comedonal acne हो या फिर papillary acne हो, in all those things we can go for a topical retinoid. But if the question, I just want to confirm, yeah, अगर severe acne vulgaris दिया है, then the answer should have been systemic isotretinoin because it comes in a tablet. So they usually, yeah, Anjali is saying that there was acne on the back. See, what happens is acne usually we get few lesions over the face. But in case you get lesions over the trunk as well, this is usually going to be a severe type of acne. And so if it is going to be severe type of acne, then the answer should be isotretinoin, because the usual thing what we follow is for every mild kind of acne, we start with a topical retinoid, just say only some comedonal lesions and all. So we start with topical retinoids. If there is something more, then we may have to go for a topical or oral antibiotic has to be added. Topical or oral antibiotic has to be added to it. But in cases the lesions are going to be very severe, then what we do is we will be going for oral isotretinoin. So that is a usual methodology for the treatment. So acne vulgaris on the face and trunk and comedons were seen in the face image. Sir, the history of acne on back was also given. Agar there is a history of acne over the back as well, because आप सबको पता है कि normally acne कैसे present करते हैं, because you will be getting a lesion over the face. These lesions may be 5 in number, 10 in number, 15 in number. So number of lesions can increase. But whenever you get a acne over the trunk as well, this is usually going to be a severe type of acne. So the better answer here should be isotretinoin. Yeah. Kailash, about nodulocystic, we usually call a severe acne if the morphology of the lesion is going to be nodules and cysts. But if the lesions here is going to be extensive, okay, if it is not limited to just 5 or 10 lesions, it is going to be extensive, not just limited to the face, but also going towards a trunk, then we will have to consider systemic isotretinoin as well. Because the other options, just say systemic azithromycin was never a first line agent for acne vulgaris. Doxycycline, it can be a possibility, but it depends upon what is the actual presentation. Okay, thank you so much. So now let's see the next one. You also got a question like this, which is going to be usually categorized under deep fungal infection, है ना? The first sentence, जैसे a farmer presents to the clinic with a swelling in the foot with a discharging sinus. In this one sentence, what is the diagnosis that comes to your mind? ये जो diagnosis होगा, Madura foot, isn't it? Madura foot. But usually every time what happens, they always ask you regarding Madura foot with in respect to a fungal infection, right? But see the second sentence, the stain from the lesion, it shows a gram positive filamentous structure. So is it? Yeah. So if it is going to be gram positive filamentous structure, simple thing, if I ask you, is Madura foot a purely fungal infection? The answer should be no, isn't it? Yeah, Madura foot, it can be either fungal, which is more common obviously, or it can be bacterial. So if it is fungal, we usually call this as eumycetoma. And if it is bacterial, we call this as actinomycetoma. Mycetoma. So here the examiner has clearly told you that we are having a gram positive organism, which means it is a bacteria. So this is a case of actinomycetoma that was asked. So in this actinomycetoma, they mentioned about the filamentous structure. Is it Aspergillus? Is it Staphylococcus aureus? Or is it Nocardia? Yeah, so this is going to be Nocardia. Yes, KK, I'm talking about shift 2 questions in dermatology. Okay, shift 2 question. So this here should be Nocardia because it is a filamentous structure, gram-positive bacteria. Very rare, but it can also be caused. है ना? But if it is Staphylococcus aureus, it would not have been a filamentous kind of a structure that we all know. I guess one of the options in this question was also Sporothrix, isn't it? One of the option was also Sporothrix. The Sporothrix schenckii, it is also causing a deep fungal infection. But usually क्या होगा, multiple nodules will be seen that is arranged linearly in a lymphatic fashion, isn't it? So that is how the usual presentation is, and it is a fungus. It's not a gram positive filamentous structure. So Sporothrix schenckii is a fungal infection. It's a deep fungal infection. So here the right answer should be Nocardia brasiliensis, which can also cause this condition called as actinomycetoma. Okay. Yes, regarding that question regarding acne, if you think that that was a kind of a moderate acne, because the question which I gave you today, just now what we discussed is, I mentioned about severe acne. Since it is severe acne, that is the reason why I'm saying that the answer should be isotretinoin. In case the question or the image that was given was not nodulocystic, if in case the image did not have too much of lesions over the face or trunk, then if you consider it as a moderate kind of acne, then you can definitely go for a oral antibiotic as well. Okay, oral antibiotic as well, because usually in adolescents, because somebody is saying 18 years old was given, if it is an adolescent who is having an who is mentioned age is 18 years old, in such cases we obviously go for very common things like minocycline, isn't it? So that can be an option as well. So if it is moderate acne, please take it as antibiotics, but if it is severe acne, please take it as isotretinoin. Okay. So now let's go for the next one. Abhi, you got one more question regarding a urethral discharge. So a patient presents to a clinic with a painful urethral discharge. Can you please confirm agar painful urethral discharge bataya tha in the options in the question or not? You know? So if it is a painful urethral discharge, we know that the patient can present to you either with a painful discharge, which is going to be mucopurulent kind of a discharge, or it can be a mucoid discharge. So in such cases, we are going to cut down our differential diagnosis into two. So what are the two options? It can be either a gonococcal urethritis. In the other case, it can be a non-gonococcal, isn't it? Non-gonococcal. So if it is going to be a purulent discharge, patient is having severe dysuria, pain and all those things, then it is more likely to be gonococcal. Gonococcal will show you severe symptoms. Whereas non-gonococcal, this will show you mild symptoms with some mucoid kind of a discharge. And this is usually caused by chlamydia trachomatis and all, isn't it? So here, yeah. So can anybody tell me what is the right answer here? If in case if it is mentioned dysuria, pain or urethral discharge with pus and all these things, and in case the image which was given was something similar, then is it doxycycline or cefixime? Because one goes along with non-gonococcal, one goes with gonococcal. So what is the right answer? Yes, thank you for confirming this image was given. Uh, Unprotected intercourse 4 days back and then the same image. Super. In that case also, unprotected intercourse, same image where you can see a pus kind of a purulent discharge, then the answer should be cefixime. Why? Because our diagnosis here should be a gonococcal urethritis. Take a gonococcal urethritis. In case it was a scandi mucoid type of a discharge, then the right answer should have been a non-gonococcal thing. Okay? The option was doxycycline for 14 days. Yeah, cefixime was also mentioned, right? Yeah, if cefixime was mentioned, that is obviously going to be the first line agent of choice. Okay, someone is saying that cefixime 400 mg was mentioned. Okay, if the dosage is different, still fine. It is going to be cefixime itself, which is going to be the right answer in case of gonococcal urethritis. So now let's see the next one. Now, what about this? You got, I guess, two questions from urethral discharge or vaginal discharge area, right? Okay, okay, noted. It's no, it's 400 mg that is given, not 800 mg. Pakka, no problem. But still, the answer is going to be cefixime for you because it is going to be a gonococcal urethritis. Now, a middle-aged sexually active woman presents with a foul-smelling, watery vaginal discharge. What should be the most probable causative organism? See, whenever it comes to vaginal discharge, we usually cut down our differentials into few. What are the differentials? If it is a curdy white discharge, let us say that this is going to be candidiasis, where we have a curdy white discharge. Whereas in case the patient is having a presentation of a greenish colored frothy discharge, so that can be because of, yeah, trichomoniasis. And the next one, where you get a foul smelling discharge, this can be because of bacterial vaginosis. So what is the most likely thing among all these things? This question was not there. So did this question come in the paper 1 or paper 2? Because many of them have shared the same thing, saying that there is a foul smelling discharge. The Nugent score was asked. Okay, so in case it was a foul smelling vaginal discharge, and obviously the right answer should have been Gardnerella vaginalis, isn't it? Because it was bacterial vaginosis. Okay, noted, fine, no problem. So I guess these are the questions that I could collect from dermatology. So not too many questions, but I guess there were some questions about arthroconidia and all regarding the hair shaft disorders. And Mamta ma'am has taken up that topic. She has already discussed with you, isn't it? So these were all the basic questions that was asked this time. So I hope whatever questions asked, yeah, there was something, yeah, there was some other question which in which clue cells were given in bacterial vaginosis. Okay. Nugent score was asked in bacterial vaginosis. Scalp patchy hair loss. Scalp patchy hair loss, I guess it came in the paper 1 as well regarding tinea capitis, isn't it? What was the other question? Because these are the questions which I could collect. So any other questions if it had come? Yeah, pemphigus image to already bataya na, because pemphigus was the first topic that we discussed, the fishnet pattern of DIF. So fishnet pattern in direct immunofluorescence, the right answer should have been pemphigus vulgaris. In case the option was pemphigus foliaceus, foliaceus will also show you a fishnet pattern. Okay? What is the question from alopecia areata? Because I did not get it separately. Some of you are saying alopecia areata, if there is a patchy hair loss. I guess in the first, you're talking about the paper 1, because yesterday a patient who is having a papillosquamous eruption also over the groin area, having some multiple patchy alopecia. So multiple patchy alopecia was seen in secondary syphilis, where we have, yeah, it was seen in secondary syphilis. So just let me know, in paper 2 also it was asked. Acha, in paper 2 also it was asked an image based question. So please try to drop me or just let me know in my Insta page by direct message. Dr. Jazeer Dermatology. Okay. Anyways, we'll be coming up with a more detailed discussion after verifying all the questions once again. Okay. Done. So brother and sister was affected because of alopecia. In case it is brother and sister, less likely that it can be alopecia areata, because alopecia areata is a autoimmune condition. If both the siblings are affected, just start thinking like it should be an infection. More likely, more aligned to tinea capitis or something. Okay. Fine. Okay, was pediculosis also asked? Because I did not get these questions during the recall thing. So yeah, typical image of alopecia, I'm just noting it. And Pallavi says that pediculosis was asked. If you could confirm whether pediculosis was asked, then I can make a note of it as well. Okay, 𝐒𝐿𝐴𝐂𝐈𝐀. So anyways, thank you so much. We have other live sessions also scheduled by other faculties. So happy learning, and we will be in touch. We'll come up with a very detailed discussion on all the questions, both paper 1 and paper 2. And thank you for all the feedback, guys. So wishing you all the best for your exams, for your results, and we'll be in touch. Thank you so much.